Welcome everyone. I am Pam Fury, System Manager for CDI. This session is focused on documentation of diagnosis related to respiratory failure. As a reminder, much of the content presented can also be found on your tip sheet pocket guide and or posters placed in the physician documentation areas. I will be reviewing 3 scenarios which present the biggest challenges we have for documenting respiratory failure diagnosis. I'll first take you through each of the 3 scenarios and then what the guidelines are, acceptable diagnosis, and then we'll run back through these same 3 scenarios for what was actually documented and what would have been the appropriate diagnosis. So the first scenario that presents the biggest challenge is when a patient is presented to the ED and they've already been intubated in the field. A patient's brought in by ambulance after a witnessed collapse. CPR is initiated. Upon EMS arrival, the patient was in PEA, arrest, then VTAC, so they were intubated due to a Glasgow coma score of 3. The physician documented, quote, concern for devastating anoxic sequel. The history of the patient, they're from a skilled nursing facility. At 4:30 at the facility, they were found tachypnic with rapid shallow breathing. Upon arrival, the chest to the ED, the chest x-ray was negative. The ABGs were a pH of 6.94, PCO2 of 58, PO2 of 290, FiO2 of 98%, and the patient was on the vent. The second scenario that we often find is a challenge for documenting acute respiratory failure is when a patient presents with acute respiratory failure and they have an underlying condition. So in this particular scenario, the history of the patient is past medical history of COPD on HOMO2, and they're a smoker. When they arrived to the ED, it was a 56-year-old that presented with, quote, respiratory distress and confusion, also using the accessory muscles for breathing. The ABGs upon arrival were a pH of 7.4, PCO2 of 88, PO2 of 53. Their O2 sats on room air were 89% with a respiratory rate of 24 and a heart rate of 140. The impression that was written by the physician of COPD exacerbation and respiratory acidosis is also a correct impression, just not complete. And this particular patient was treated with BiPAP. The third scenario that also often presents challenges for documentation of acute respiratory failure as a proper diagnosis is when a patient presents with a trauma and or any other condition and a physician ends up writing airway protection. In this particular case, it was an automobile versus a pedestrian. The patient required bagging to maintain a SAT of 96%. They had a Glasgow coma score of 6. They had reduced breath sounds bilaterally. The ETOH on arrival to the ED was 0.386. Bilateral chest tubes were placed due to bilateral pneumothorax. This patient has a history. They're a 45-year-old with a history of alcohol abuse. They did have stable vital signs. But upon arrival, they had to intubate the patient right away for, quote, airway protection. They did have a respiratory rate at that time of 24 with a heart rate of 104. On the vent, the patient's ABGs were 7.34, PCO2 of 44, PO2 of 78, and an FiO2 setting of 60%. So when a patient is presented with the clinical evidence and the clinical criteria in any of those 3 scenarios that I reviewed, there are about 5 different categories of options for respiratory diagnosis. And I'll outline the 5 categories here. You can simply have a diagnosis of acute respiratory failure, and you just must indicate if it's hypoxic or hypercapnic. You also, though, could have acute respiratory failure as a diagnosis that is secondary to a pre-existing underlying condition, like that one scenario of the patient with COPD and on HOMO2. So you simply would write a diagnosis of acute respiratory failure secondary to pre-existing underlying condition of COPD or of CHF or of pneumonia. A third option for a proper diagnosis of respiratory failure is when a patient has acute respiratory failure, which is secondary to decreased ventilation, which is also secondary to a condition that that patient presents with. Decreased ventilation can be caused from a trauma, like we saw in that automobile versus pedestrian, from a brain hemorrhage. Decreased ventilation can be secondary to a CVA, to a drug overdose, to an oversedation. So acute respiratory failure, secondary to decreased ventilation, which is secondary to the condition that you specify. That's a very appropriate way to write a proper acute respiratory failure diagnosis. Another approach to writing a respiratory failure diagnosis is if the patient is acute on chronic, which does happen quite frequently with COPD patients. And in that case, if you write acute on chronic, you just want to write if it's hypoxic or hypercapnic. And then lastly, sort of the fifth category, if the patient just has chronic respiratory failure. Anybody that's a COPD on continued HOMO2 does have a diagnosis of chronic respiratory failure. The guidelines for respiratory failure. So the guidelines are pretty clear. The patient must present clinically with symptoms, signs and symptoms of respiratory distress. Again, that's not a diagnosis, but those are signs and symptoms, and meet one of the following criteria. So what constitute a sign and a symptom of respiratory distress? The patient's dyspneic, they have dyspnea, they have a respiratory rate over 20 or less than 10, they are wheezing, labored breathing, nasal flaring, accessory muscles, use of accessory muscles to breathe, retractions, or cyanosis. The criteria for diagnosis if the patient is hypercapnic is if the PCO2 is over 50 with a pH less than 7.35, or perhaps it's 10 to 15 points higher than the patient's baseline. The criteria of a patient is if they're hypoxemic is a PO2 less than 60 or an SpO2 of less than 91% on room air, or you can have a 10 to 15 points lower than the patient's baseline, or a PF ratio less than 300. So sometimes in a few of those scenarios that I mentioned that present a challenge to us, the patient comes in already intubated, or they get intubated when they're in the ED and they're already on a vent. So if you do not have a SpO2 on room air, or ABGs without being on the vent, then you have to use the PF ratio. So here are two different ways you can calculate the PF ratio. You take the current ABGs, since they're intubated and on a vent, and you calculate you have a PaO2. You divide that by the FiO2 vent setting, and then you get your PF ratio. So, and this is just an example, if the PO2 is 90, and the patient's on an FiO2 of 40%, then the calculation is 90 divided by 0.4 to give you a PF ratio of 225. If you do have a current SpO2, your calculation is if you have an SpO2 that's less than 91%, that's equal to a PO2 of 51 to 58. So that calculation is that PO2 is equal to a PO2 of 51 to 58 is equal to a PF ratio of less than 300. Okay, back to the first scenario that presents a challenge is when the patient is intubated in the field and they're brought in here. If you remember, the patient was in PEA arrest, then VTAC, and they were intubated in the field due to a GCS score of 3. And what was documented by the physician was concern for devastating anoxic sequel. That is appropriate clinically as an observation and an assessment criteria, but it is not a diagnosis. If you remember those ABGs after intubation and on the vent, I'll just remind you again, we're 6.94 pH, PCO2 of 58, PO2 of 290, FiO2 of 0.98. The original diagnosis of concern for devastating anoxic sequel is not appropriate, and the patient will never be, the diagnosis of having acute respiratory failure will not be captured unless you, in addition, write a diagnosis that states acute hypercapnic respiratory failure. The criteria that you used to determine that was the PF ratio and your EMS assessment and your assessment in the ED. Second scenario that presented a challenge is when a patient comes in with acute respiratory failure secondary to an underlying condition. If you remember, in this case, the patient had a history of COPD on HOMO2 and they were a smoker. The physician documented respiratory distress, and that's great clinical evidence and clinical criteria for having distress, but remember, it's a symptom and an assessment. They were using their accessory muscles and they were confused. Now their ABGs were 7.4, PCO2 of 88, PO2 of 53, with an O2 sat on room air of 89 and a respiratory rate of 24 and a heart rate of 140. This patient was treated with BiPAP and an appropriate diagnosis of COPD exacerbation, and also respiratory acidosis was also written. However, it was not complete. In addition to those two diagnoses, which are recognized diagnosis, the physician also could have written acute hypercapnic respiratory failure secondary to a pre-existing condition of underlying COPD exacerbation. And your criteria, again, was your vital signs, your physical assessment, the patient's history, and the ABGs. The next scenario that we see that's a challenge is when a patient comes in with a trauma or a physician documents the patient was intubated only due to airway protection. Remember, in this particular case, this was a trauma, an automobile versus a pedestrian. The patient had reduced breath sounds. They had to be bagged in order to maintain a saturation of 96%. And they had bilateral chest tubes placed due to a pneumothorax. They were intubated. They had a respiratory rate of 24, heart rate of 104. Their ABGs on the vent were 7.34, PCO2 of 44, PO2 of 78, and FiO2 of 60. And the physician documented originally airway protection, and you always are intubating for airway protection. In this case, though, a proper diagnosis would have been acute respiratory failure, which was secondary to decreased ventilation, which was also secondary to a trauma. Remember, you can have decreased ventilation due to a CVA, due to an overdose, due to a hemorrhage. And so it's best to write acute respiratory failure secondary to decreased ventilation, secondary to that condition. And your criteria is obviously your PF ratio, your physical assessment, and the patient's vital signs. Just a couple reminders. Respiratory acidosis is a diagnosis, but it is also equivalent to acute hypercapnic respiratory failure. So in addition to that, you must document acute hypercapnic respiratory failure. And another reminder is respiratory distress is not an accepted diagnosis. You must document acute respiratory failure or chronic respiratory failure. And that covers most of the challenges we have related to respiratory failure. And I just want to thank you for being a very valuable member of the team and working together with our clinical documentation department.